That was an area that was fingered by the parliamentary committee as well. Yes, Dr. Lesiyampe, you had a point earlier on.
Thank you very much, Hayub. I just wanted to follow up with what Dr. Lichenga said. I agree and I respect the fact that we need the private sector. We need the faith-based hospitals really to support us and help Kenyans. And I'm happy to say that I think for the first time, I think SHA is actually bringing all of us on board, creating equity, creating inclusiveness, and creating probably expanded services to Kenyans. I would just like to mention one thing, and forgive me for going back to history. I'm also an historian. Okay. NHIF was established in 1966. I think most of you are not born. 1966. And it was basically to provide some services, actually to employees who are on regular pay. The same system, was actually reviewed, I think, in 1972, piecemeal, I think, review. It also was reviewed, I think, in 2009 and 2018. What I'm trying to say here is that I think a system that was established in 1966 cannot support us today. It can't.
Things have changed.
Things have changed. Disease burden have changed. I think even our orientation has changed. Technology has changed. We are using cards, I think, with NHIF. Now we are not even using cards. In fact, you register automatically. You don't need to have a card. Mm-hmm. And I think when Dr. Lichenga mentions the issue of pre-authorization, I agree that probably there could be some errors, that will be, seen or actually be experienced. But I think the system also has a mechanism whereby it actually follows, from, the placement of the claim. It also actually checks whether the appropriate documents, which are scanned, have actually been included. You can actually monitor it until it is received at SHA headquarters. You also see it, in fact, through the system, whether it's actually accepted or rejected. And I believe there is a default mechanism. If the figure is 32,000 for CS,
yeah.
There must be a default mechanism that it cannot allow any figure for CS to be more than 32,000. So I believe that some of these things, I think, progressively can actually be corrected.
And his point was then, how do we remedy? Because
yes, so that's why I'm coming
human error can be.
So what I'm trying to say is that
we are susceptible to making errors, but in such situations, then yes, it's not logical for a CS process to be 320,000 Kenya shillings.
Yes.
But how do you then remedy that within the portal, within the system?
Yes, and that's what I'm saying. I'm not here defending SHA, but I'm trying to just to be a leader and actually an individual running a facility like that of like Jaramogi Oginga Odinga. That some of these errors, for example, I think it could be. I know it's very serious. A zero is very, very important.
Yeah.
You can't just ignore it. But the point here is that we cannot actually throw, water and the baby in a basin. I think these are some of the things that can be corrected. The other thing that I would like to say is that, NHIF has been here, I think, for 58 years. And it has actually progressively improved on its services. In fact, it was a system that introduced, additional services continuously on a piecemeal basis. This is the first time that we have actually tried to go to SHA to have a whole comprehensive, revolution in terms of, universal health care. I think Kenyatta one, did establish in 1966 established NHIF. His Excellency, the President Mwai Kibaki and Uhuru also attempted. This is the first time I think we are saying that we want to go the whole hog. And basically for me, sitting here as a head of a referral facility,
all right,
I think this is a momentous time for us. And therefore, some of these challenges, we actually need to agree that we need to correct the system. But what has happened so far the last 35 days, for me, for example, actually admitting a patient through NHIF was taking 7 days to get approval, sometimes even 14 days. The fact that today I can actually admit a patient within 4 minutes, it's actually a great relief, not only for me, but also for the patient.
Okay.